Thanks for joining us for Wake Up with Patient Safety. I'm Ashley Digiovanni, and I'm with the Patient Safety and Enterprise High Reliability team. I'm so happy that you decided to wake up and join us today. Each month, we have new guests with us, from frontline associates to top leaders, to talk with us about the overarching focus around patient safety and the work we're all doing around it. So grab your favorite morning beverage and get comfortable as we dig in. Our guest today is Director and Physician Executive Dr. Diane Hibbs with Physician Relationship to talk with us about the two leading causes of death for pregnant women here in the United States, which are hemorrhage and complications with high blood pressure. She will discuss what we are doing here at Cerner to help medical providers recognize and react to the signs and symptoms earlier in their workflows. Thank you so much, Diane, for joining us today. I'm really excited to dig into this topic, as I think a lot of people are going to be surprised to hear some of the statistics and stories, but I'm excited to hear the steps that we're taking to improve and recognize those signs and symptoms earlier for our clients and their patients. So let's start off with something you sent me, that in the last 25 years, the US maternal death rate has increased by nearly 50%, while the global maternal death rate has decreased by 30%. As an obstetrician, how did this make you feel, and what were your thoughts about how we could take steps as a company to get more involved?
Thank you so much, Ashley. I'm so excited to be here to talk about this. Although it's not a pleasant topic at all, but I am excited about what we can do as a company. First, I want to back up just a little bit and talk about the statistics, because they were shocking to me, both appalling and embarrassing as an obstetrician, that we're doing such a poor job in the United States when we have so many resources. It just is mind-boggling to me.
So much, yes.
Right? So I want to just you're right. In the last 25 years, the death rate, maternal death rate, which means a death that is associated with pregnancy or 42 days after pregnancy, so that postpartum period as well. So that has increased over the last 25 years by about 50%. So in the United States, we have about 17 deaths per 100,000, a little more than that, 17.4, which is it just has gone up so much. It's doubled in the last 25 years, while it has decreased in other countries that have the same types of resources. In France, in the United Kingdom, in the Netherlands, all of those European countries, it's just mind-boggling.
It is.
So a lot of people will talk about, well, why is that? Why is it so bad in the United States? And at first, I really thought, oh, that cannot be right. There's no way. Then I started digging into it, and a lot of the reasons that you hear are really excuses, I'm going to say. Reasons like lack of access to care, racial disparities, lower income, higher risk. Here's what you'll hear a lot. Well, our patients are higher risk. Okay, so they are getting pregnant later in life, so higher or greater, the age is higher. Okay, so older women, obviously they have more chronic health problems as they get older, so they're at more risk. We have a higher rate of obesity, so that increases the risk for a lot of those things. But I don't think we can blame the patient, right? So, we really have to. Right. Yeah, ideally, patients come in and get their care. They take good care of themselves. They're healthy before they get pregnant. And, they have a good weight, and their labor goes well, and everything is good, right?
Yeah.
That's what we want. but we can't blame the patient. We need to, step in where we are and, and deal with it. So I'm excited that we have an opportunity as a healthcare company to make a difference. I think that it's going to take a lot more. We have already created some solutions, and I'll talk about that in a little bit. But we're seeing not as much adoption from our clients of those tools as we'd like to see. So so there's a lot. There's a lot to unpack here.
It is, so scary. And when we first kind of started talking about this topic, I was just like, what? I was very surprised. And I did, you sent me some stuff. I did some additional digging, and it's so surprising. And I even was telling some friends, like, can you believe this? I'm going to do, this podcast, and I'm going to interview this doctor just about this stuff. And my mind is blown.
Yeah.
It's crazy. So what are some of the other countries that have that, you talked to that are doing, good, that we're, failing at, but.
And why, right?
Yeah.
So we look at United Kingdom and they have nationalized medicine, and I'm not going to get into any political statement or anything like that. But what I will say is that they have good access to care, right? It's just kind of a guarantee you're going to get care. And they have standardized protocols. Now we have adopted those well in other areas, let me say. So like in the emergency room, if you come in and you're having a heart attack, they have protocols for door to treatment times, and ways to get those treatments started much earlier. Automatic protocols, nurse driven sometimes, so that so you're not waiting for a provider to come see somebody. So that's a lot of what we need to be doing in labor and delivery as well, because there's not always a physician there. So that's one thing. We've adopted protocols in surgery where we have safe surgery protocols to be sure that we are operating on the right patient and the right side and the right organ and all of those things. So we have adopted policies. I'm going to give you a little story, just a little.
Yeah, please.
So I just want to tell you about using the electronic medical record in practice. Initially, my very first experience with the computer suggesting, I had a pop-up alert that said, consider a C-section. And I just wanted to throw the computer across the room like, are you kidding me? I know what I'm doing. Don't tell me how to practice medicine. So I just blew past that alert, which I think a lot of providers, as they see these pop-ups that are interrupting their process, their thinking, I just want to get that out of my way. I'm thinking about what I need to think about, and I don't need the computer to tell me. Now, at the same time, I'm gonna take it back now, because then I kind of came around to, if I am thinking something different than the protocol, I probably ought to be documenting why I'm thinking something different, and so it's a good opportunity to document that stuff. But what I want to say is that those alerts, if we can build them in so that they're not interruptive and they're not, they need to accomplish, the protocol without being so interruptive, I guess.
That makes sense.
Yeah. So, we have the opportunity to provide kind of that safety net to be sure that these patients don't fall through the cracks, the blood pressure that nobody noticed. Well, we have a machine that is monitoring that. So there are some national organizations that have created protocols for us. So we have our national colleges. We have the American College of Obstetrics and Gynecology that has protocols. We have the, I always have to look at the abbreviation for this because I always say the wrong letters, but California Maternal Quality Care Collaborative, which really has come out with some really good protocols, and bundles, safety bundles. So the problem is, how do we, not the problem, but I guess the challenge, how do we get that information, those protocols, into our workflows and make them more automatic? So I think that is where we have the opportunity.
Definitely. I definitely agree, especially the automatic part, because you were talking about it kind of interrupting and building it into the workflow. How can you make it more intuitive and that automatic instead of interrupting the thought process and the flow of the provider? So that makes definite sense there. How can we start to build that in? Right. And you talked about that, like the low income and, those excuses. I grew up really poor, and I worked in healthcare, and I worked for a provider that was OB focused, and I seen lots of patients that came in that also had they were on Medicaid. My sister had a baby, and she was on Medicaid, and as soon as she had that baby, which they also made her have a C-section, which I don't know if it was not technically she didn't have any complications, but she went in and they just did a C-section, but she was done, because she didn't have Medicaid after that, and her job that she had didn't have insurance, that there was nothing else that she could do. They were done with her, and it's just scary. Thankfully, she didn't have any, she's still alive.
Right.
But, think about all the other women that, have complications, or they had complications during pregnancy because Medicaid, only covers for certain types of things while that pregnancy. So that's so scary and frustrating.
Yeah.
So I want to ask, could you actually tell us a little bit more about the maternal mortality? I know that I believe there's 3 commonly used measures around the maternal deaths in the United States.
Yeah, I'll clarify that a little bit. Perfect. There are a lot of different definitions, and that's part of the problem that we've seen with reporting these kind of things. For instance, 2003 in the United States is when there was a checkbox added to the death certificate that indicated it was pregnancy related. And so before that, we were probably underreporting. And so since then, so then it's different in every state, the reporting. And so, the statistics that we get, the data that we get from each state is different. And so it's really hard to put that all together into national statistics, I think.
So you mentioned the hemorrhaging, well, I guess I kind of mentioned it also, but how it's really big, which are the big leading causes are hemorrhage and the complications with high blood pressure. So I'm guessing that kind of leads into those, main issues around the maternal death. I'm sure there's lots of cases, but those probably are some of those key points.
Yeah, and it depends on when you look at the, are you looking at this year? Are you looking at the last 5 years? Are you looking in different states? I mean, the leading causes will vary. So hemorrhage might be leading, and then hypertension is leading. And I'll tell you, actually, in Arizona where I live, the leading cause is suicide.
Oh, probably because depression.
Yeah, so I mean that's a totally somewhere else to go, with this whole.
Yeah.
So I mean, there's a lot of, we just have such an opportunity here. Undiagnosed depression, substance use is a big problem, and high blood pressure. Those are the ones that I feel like we can automate a little more as far as measuring and treating and those kind of things. And so those are the things that we have concentrated on first. Additionally, I have been working with the Society for Maternal Fetal Medicine to create order sets and clinical decision support to go along with their guidelines, basically. So we're taking their guidelines that they have already created and kind of embedding them into our electronic medical record to try to automate those things. So the first thing that we worked on was hemorrhage, and we created, together with SMFM, we created an order set that is available to our clients right now that is sanctioned by SMFM. So it encompasses all of their guidelines for that.
That's great.
So, and then right now we're working on the hypertension module. So we're going to include clinical decision support with order sets and education for providers and for patients regarding hypertension. So
that's great. And when I worked, now this was, I've been with Cerner for a little over 5 years, and when I worked for the OB doctor, well, she did family practice in OB, but so it was a while ago. But we talked about depression, and I don't even remember. Like, I feel like it should be something after they come in for a follow-up, like why are doctors, maybe they are, but not even asking, like, it should be a protocol of like doing that, that depression screening right after.
And we do have that now. It is that's one of our forms that's in our EMR. So that is automated. I'm not sure if follow-up is necessarily, but we are definitely doing the screening for it before the patients leave the hospital.
But they're not usually hitting that depression right before they leave the hospital, It's that follow-up care that is that lacking, I feel like.
Yes.
Yeah. So this is all really, great. And good to know the differences, between those. And a lot of people think that it's death. Just, hearing this, I first thought like, just the deaths during delivery, but it's not, talking and even researching and stuff that you sent me, it's also deaths during the whole pregnancy that it's accounting for, right?
Right. Yes. And after. So up to
like the whole post.
Can be pregnancy associated up to a year later. The National Quality Forum has just come out with some new recommendations as far as pre-pregnancy measures, pregnancy measures, and then postpartum measures, so that it really encompasses the whole life of the mom.
That is fantastic. That's great.
Yeah.
So most maternal deaths are preventable. It's just, what are we doing to really do them, right?
That's interesting because, when I first read it, I'm thinking, these must have been like super sick patients. And, actually what the statistics show us is that 3 out of 5 deaths are probably preventable. That is very sad. It's very, again, embarrassing, appalling. I mean, where are we missing it? Are we missing the signs? Are we missing the diagnosis? So we've got to figure out how to catch those things earlier and, again, put that safety net under them so that we aren't losing those moms.
Yeah. I think I read something about like, the women that, were bleeding to death could have been saved if the signs and symptoms had been recognized earlier and interventions were instituted. And then like the hypertension could have been prevented the same type of way if we were, monitoring the blood pressure better and they were assessed like 15 minutes
so I think
after something.
Yeah, I think if you're not familiar with labor and delivery, I mean, you think, well, how in the world could she bleed to death and nobody notices, I mean, so I'm going to walk you through a little bit of that. So so maybe I'm the one doing the delivery and she bleeds a little more than normal, and I write that down, but not terribly. And so, but then now I go off shift and somebody else comes in and they look at her and they're like, oh yeah, she's bleeding a little more than normal, but not terribly, and then the next person does the same thing and pretty soon she's way down and nobody really notices because it's been gradual. It's been a lot, but it's tolerable each time, but when you add it all up, it's not. So one of the tools that we have already put out is the blood loss calculator that is part of Cerner. It's part of Power Chart Maternity. It's an M-page that basically you can document each thing by weight. So each pad that you take off the patient or off the bed, all the bloody stuff. I know that's kind of gross, but you weigh it and keep track of that on this M-page. So there's a running total for each provider to see, right? So that's one of the tools that we have come out with over the last couple of years that I haven't checked lately. I should probably check again, but the last time I did check, a lot of our clients had not downloaded the package that included these tools. And so that's a little bit disheartening as well, because if we put this stuff out there and then they're not using it, then what?
Yeah. And that kind of leads me to my next question, because you had mentioned, it's out there. So, how can we help our clients to know, like, this is out there and we can help improve? Maybe they don't, I just don't know, but
maybe they don't know. Right. Or so maybe they've already created another solution on their own. And so they don't need this. I think what's going to help is when we are cloud deployed and all of those kind of upgrades and new functionality is kind of more automatic. So it'll be there. I think that's really going to help in these kind of situations because, again, we can create stuff, but if they're not going to use it,
Yeah. And I think that it's such a huge thing that can help, their patients and, not just like, oh, we need to get the United States better, but it's all about helping the patients overall. Right. And, it's just, that's such a low number of our clients that are utilizing these tools that we have that can help them. And you said maybe they've done something, as a workaround, but it's not being charted maybe and integrated. So how can we even help to get that out in front of them?
Yeah. So, and I think we are doing some. We have a women's health council. So our clients come together, and so at least they're hearing about the new things. They are weighing in on some of the decisions that we're making about where we put our resources and things like that. So that's an opportunity for our clients to get involved in what is being developed and that kind of thing.
That's good. I'm really glad to hear that we're really striving to make changes for our clients and their patients. Can you tell us what are the things? I know that you've already said the things that you have completed, but what are the new things that you guys are working on now or that are about to come out?
Well, so the blood loss calculator is out, but it has a new enhancement. So it's better than it was. And so always getting better. We also have a couple of rules that are baked into the background kind of that are monitoring vital signs. And so the maternal early warning score or, that kind of thing. Yeah, Muse. And again, some clients may have already created their own, but this is what we created so that any of those changes are noticed, more readily, so that we can treat them. the order sets and things that I talked about putting in, in concert with Society of Maternal Fetal Medicine. We're working on those things as well.
That's awesome. That's really great. Those are really good steps that, we're taking. Do you have some pilot clients that you're looking to pilot any of these new things and monitor how they're using it and monitor the data around maybe?
We do, but we're always looking for more.
Oh, good. Maybe if anyone's listening and they have some clients that want to, they could reach out to you maybe?
Definitely. Yes, definitely.
That's great. So they can reach out to you if they have ideas of maybe they have a client that they want to, get involved
definitely.
With possibly piloting this. And then you guys are monitoring how they're using it and that data.
What my goal, Ashley, would be is that we can show that women who deliver in hospitals that are using Power Chart maternity have better outcomes and, safer deliveries. That is my dream. So
that would be great.
Wouldn't that be awesome? So
that would be amazing.
Yeah.
Well, this has been awesome. I can't wait to hear what comes out of the pilots with clients. And we'd really love to have you come back after those pilots to tell us a little bit about how it went, what it's looking like, as well as, how we're doing towards that goal of maybe our clients with our Power Chart, and as well as what we've learned and what we're doing to take what we've learned to that next level.
Yeah.
I really want to say thank you so much for shedding some light on this and for sharing what we're doing to make a difference here at Cerner. Also, thank you for taking the time to talking with us today.
Well, thank you so much. It was a pleasure to come and talk about this, although I wish it was better news to talk about.
I do want to ask if you have any parting comments you'd like to end with for our listeners.
Ashley, it would be awesome if there are other clients that would like to join the Women's Health Council. If there are clients who have created some solutions that are interested in kind of partnering with us to, get those out to more clients, that would be great. I'm just always interested in talking with anyone who has a passion for this. So I'm happy to talk with anyone.
That's good. And also, if anyone knows of any clients that aren't using it and maybe want to know more information about it, how can we, enlighten them and educate them on why this will be good for their patients? That might be good too.
Yeah, definitely. Yeah.
Thank you again. And thank you everyone for joining us today. And make sure to join us next month for our next video podcast. We have a client interview, Dr. Diego I. Ludslow from Intermountain. Remember, each month we'll have new topics, new guests, but always our favorite morning beverage. Also, don't forget to complete the feedback survey so that we can continue to bring you valuable information.